as for the general topic, I am Dr. Ellen Hayes, joined by Dr. Rodrigo Pagani, and we are talking tonight about male fertility. So a basic 101 type lecture. And so I'm going to flip to our next slide. So I'm a reproductive endocrinologist in the Kindbody Milwaukee office, and Dr. Pagani is a fellowship trained urologist. He can probably speak for himself too. I guess I don't need to talk for you, Rodrigo. Do you want to tell them your background and your expertise?
Yeah, so thank you very much, Ellen. Yes, I'm a male fertility specialist. I have done my fellowship in Baylor, Texas, more than 20 years ago, and I'm helping men all over the country through the Kindbody clinics to have, their evaluation, treatment. I'm based in Miami, Florida, but I'm seeing patients in Milwaukee, St. Louis, Florida, Miami, and Orlando right now.
Perfect. Well, I'm excited for our talk tonight because I think it's really good information. And I think that what's important for everyone to know is that I work really closely with Dr. Pagani, and that's usually the way a reproductive endocrinologist, which is a fertility specialist, would work with a fertility urologist, so a fellowship trained urologist with special expertise in male fertility. That's sort of an important component once we get to the point of fertility treatment for these couples. So onward. So just a little bit about Kindbody Fertility. So Kindbody is a fertility company, and we're nationwide with multiple locations. And our mission is to make reproductive health and fertility care accessible for all people who need it. We do that by seeing patients who seek our care directly, but we also partner with employers, with industry to help provide fertility and family building benefits for people to make fertility care more affordable and more accessible. And at Kindbody, we are a full service, state-of-the-art fertility center in all of our locations. And so the things that we offer will be what most fertility centers offer, but with additional benefits and with special expertise. So we offer fertility consultations for men and for women. We do a lot of virtual consultations, and we have board certified physicians and fertility specialists who you can meet with virtually, which makes it very convenient for the individual or both partners in a couple to be able to participate in the visits. We do egg and sperm freezing for fertility preservation. We do embryo freezing for fertility preservation. We offer intrauterine insemination as well as in vitro fertilization. We're able to offer donor egg or donor sperm for individuals or couples who need that. And we are also able to do genetic testing on embryos. So you may also see in some retail areas that Kindbody offers home fertility testing as a first step too. So if you aren't sure if you're ready to jump into a consultation and do formal testing, you may find at your pharmacy that you can start with some basic fertility testing at home to kind of kick things off. Some of the unique things that we offer at Kindbody include counseling and support. So for our LGBTQ community, for those who need donor egg or surrogacy, so those using donor eggs, sperm, embryos, gestational carriers, we actually have an in-house donor egg bank as well as an in-house surrogacy agency. So we are full service for those types of needs. And I love that we also have wellness offerings too. So those that pertain to reproductive health, nutrition, so that can also be diagnosis dependent. Nutrition can focus on a diagnosis like PCOS, infertility. We offer mental health in the form of consultations as well as support groups. And some of those are specific for infertility. And some of those are specific for recurrent miscarriage or recurrent pregnancy loss. So we have a full offering and a really well-rounded offering for everyone. So as we mentioned, we are on a mission at Kindbody, and we know that fertility and reproductive care is really essential medical care. And we also know that sometimes time is of the essence. So fertility doesn't typically improve as time goes on. So we want to get everyone seen and treated in a timely fashion. We believe that it's imperative to provide access to reproductive health and fertility care, and we wrap that all up in a really welcoming and inclusive experience and environment in our offices. So obviously the three components that are required for conception. I'm going to kick off just the next few slides, and then Dr. Pagani is going to take over and talk more specifically about male fertility. But the three components: we need a good egg, we need a good sperm to fertilize that egg, and we need a healthy uterus. And in instances where reproduction or conception is happening naturally or with intrauterine insemination, we need healthy fallopian tubes. In cases where we're doing IVF, then that's not as important. So how do we define infertility? So we would define that as no successful pregnancy after 12 months of trying if the female partner is less than 35 years old. So in most cases, it's safe to try for pregnancy for about a year if you're less than 35. In women who are 35 or older, because we start to get into more variable ovarian reserve and sometimes a more rapid loss of egg supply, we usually suggest being seen for consultation after 6 months of trying. And when women reach the age of 40 or older, it's usually a good idea to seek care right away in case time really is of the essence and we're in a more critical time where egg supply is dwindling. There are definitely special considerations where it doesn't make a lot of sense to wait 6 or 12 months. For instance, if you're experiencing infrequent or no periods, so that's oligo or amenorrhea, if you have a known problem with the uterus or with the fallopian tubes, if you have more advanced stage endometriosis, or if there's a known male factor, so a sperm quality problem, it's usually smart to seek care much earlier. And so we're happy to see individuals or couples really at any point in their process, even if you're just fact finding and you want to find out about your fertility without trying. So why is it important that we're talking about male infertility tonight? I think personally it's important because a lot of women assume when they're not getting pregnant that it's because something is wrong with them. And we know that that's not necessarily the case. In fact, sort of the simplistic rule of thumb is that about a third of the time there's a female issue, about a third of the time a male issue, and about a third of the time a combination of factors. So if you combine the male factor in fertility with the number of times it's a combination of male and female factors, that's actually a pretty high percentage of the time that male infertility is contributing and important for people to understand and to learn about. Some of the other diagnoses that we see, obviously low ovarian reserve, unexplained infertility, problems with ovulation, fallopian tubes, uterus, or endometriosis. And just to talk a little bit about the basic fertility evaluation from the female side, because we'll usually recommend testing both partners simultaneously rather than piecemealing the evaluation, just because such a large percentage of the time there can be a combination of factors contributing to the delay conceiving. We do evaluate egg health, and that's a really important piece of the puzzle. So the way that we do that is through blood work as well as transvaginal ultrasound. The blood work that we use includes an FSH, or follicle stimulating hormone, and that's one that we use to sort of guesstimate egg quality and see if it looks like there's any serious problems in relation to the patient's age and what we expect her egg quality to be at that age. We also check an estrogen level because that helps us interpret her FSH hormone and kind of understand how the brain and the ovary are communicating. And we check an anti-Mullerian hormone level, or an AMH hormone, and that's the one that tells us more about the egg quantity. So in addition to those blood tests, we perform transvaginal ultrasound to check what's called the antral follicle count. So we count the number of little resting follicles with eggs that we can see in the ovaries, and that also gives us an impression of egg supply. So that's an equal and really valuable piece of information for your fertility doctor to have that we get through imaging the ovaries. The other things that we glean either through history that we take from the patient or through testing will be whether or not there's an ovulation problem or ovulatory dysfunction, we call it. Sometimes that can be a common reason like polycystic ovarian syndrome. Sometimes we're going to see problems with the pituitary gland, and that will frequently be due to something like elevated prolactin hormone levels or thyroid dysfunction, very common as well. And that also can be due to ovarian insufficiency, but less commonly so. We're usually going to see one of the first three issues if we're seeing issues with ovulation. And then the other component of the female evaluation will be evaluating the uterus and the fallopian tubes. And there are a few different ways that we can do that. Most commonly, we're going to start with what's called a saline ultrasound or a saline infusion sonohystogram. So that's depicted in these pictures here. You can see the myometrium or the muscle layer of the uterus, and here's a 3D picture of that. The black area is fluid or saline that has been instilled in the uterus with a tiny catheter, enough that we can distend the uterus and we can check for things like little polyps or fibroids or scar tissue within the uterine cavity. And we can also typically see if it looks like there's fluid, bubbles flowing through the fallopian tubes. One of the other ways that we may decide to evaluate the uterus and tubes is with a hysterosalpingogram, also known as an HSG or the dye test, as people call it. And that's depicted in this lower image. You can see the uterine cavity filled with dye, and you can see these little delicate fallopian tubes filled with dye, and then spilling dye out the ends. And that's the way we can confirm fallopian tubes are open with an X-ray versus with ultrasound. And then sometimes we'll also do hysteroscopy. Sometimes we'll do that diagnostically to look in with a tiny camera into the uterus. More often we'll use hysteroscopy if we find something we need to treat or remove from the uterus. So the things that we're looking for are polyps or uterine fibroids or abnormal uterine shape or scarring. And sometimes we're finding abnormal fallopian tubes with these tests as well. So now I'm going to turn it over to Dr. Pagani to start talking about male fertility testing and male infertility. So Dr. Pagani, just let me know when you need me to flip the slides for you.
Okay, thank you very much. First, I would like to thank everyone for the opportunity. It's such a pleasure to work with reproductive endocrinologists like Ellen, Andy Beltzes, and the whole Kindbody team. It's very important that you all know that most of the IVF clinics in the US, they do not have a urologist on site. And with that, they are not looking in more than 50% of the causes of infertility that a couple may be suffering. So I'm very, very glad to work for this group. And I appreciate very much their view, their interest in also evaluating male fertility, which is a very important component for someone to get pregnant, as you can imagine. So I just want to talk a little bit about sperm. We start producing sperm during puberty, and you may think of sperm as an assembly line where there's a baby sperm and then a child sperm and then a teenage sperm, and we end up with the adult sperm. Yeah, in order for a baby sperm to become an adult sperm, we call that maturation. It takes about 2 to 3 months for that to occur. And that's very important because whenever we are trying to do any type of treatment in males, we won't expect any response to that treatment before those 3 months, right? Because it doesn't make sense that, that you will have any response earlier than that, since it takes 2 to 3 months to mature. Sperm declines after the age of 50, and also what happens is the quality of the sperm is also declined after the age of 50. And nowadays there are very important studies linking sperm from men with older age to diseases like autism and schizophrenia. due to damage in the sperm in patients that are older than 50. Ellen already mentioned this. We think that 20 to 30% of the causes of infertility is due only to sperm, and then another 30%, 20 to 30%, it's contributing. There are causes on both sides, right? There are no doubts that the most important test to evaluate male infertility is a semen analysis, but sometimes, I would say most of the times, we also do other tests like endocrine evaluation, where we measure the follicle stimulating hormone, testosterone, which is another very important hormone for sperm production. We sometimes study the quality of that sperm, asking for DNA fragmentation. And again, when I talked about patients with age more than 50, that's exactly what happens. The DNA fragmentation goes higher, and with that, there is an increasing chance of having babies with autism and schizophrenia. And we also do genetic evaluation. We test for karyotype, we test for Y chromosome deletions, and genetic diseases such as cystic fibrosis. Next one, Ellen, please. Of course, sperm is deposited at the vaginal introitus. It goes up to the cervix and goes all the way to the fallopian tube, where it occurs the fertilization, and then the embryo goes back to the uterus lining, where it niches, and that's where implantation happens. If an egg is present, the sperm may fertilize the egg, and it forms an embryo in 70 to 80% of the time. Next one, please. So whenever we are starting a male fertility evaluation, we always start with a history of that patient, right? What current medical illness he has, what current medication they are taking, their fertility history, have they ever been able to get pregnant before, or if they have lost any pregnancy with their partners, if they have done a vasectomy, for instance, if they are using medications such as testosterone, exogenous testosterone. We know that nowadays it's unfortunately a very common medication prescribed for fertile patients trying to conceive, and we know this is harmful for sperm production. We also do a physical examination nowadays with the web and telehealth consults. Physical examination is not being done so frequently. Sometimes we can do a testicular ultrasound to overcome the inability to do a physical examination. And as I said, we also order hormonal testing, genetic testing, and a semen analysis. Next one, Ellen, please. So what do we address on a history? Again, sexual history. Do you have any issues with erections? Do you have any issues with ejaculation? And very important to say that premature ejaculation is not a problem for a conception, but retarded ejaculation and retrograde ejaculation, which is semen coming backwards into the bladder instead of coming out. This is important. Pregnancy history with current partners and former partners. Therapies that they are using, childhood diseases, for instance, and the most common one is something that we call cryptorchidea, which is one of the testes not down there in their scrotum. Sometimes the testicle may be higher in the inguinal canal, and this is correlated to infertility. Surgical problems like vasectomy, as I mentioned, and gonadotoxins are toxins that can affect sperm production. The most common one is heat, right? But there are, of course, the PBAs that we see on plastic. We know some medications. We know about some pesticides that we use in agriculture. So these are all important gonadotoxins. Next one, please. The very important question that we need to ask when we are doing a semen analysis is, what is a normal semen analysis and what should be the average semen analysis? And this is important because the way the World Health Organization decided what is a normal semen analysis, what are the values that should be looked for, reflects actually only 5% of the patients who are unable to conceive. So in other words, can we go to the next slide, Ellen? So these are on your right here, what the World Health Organization considers normal sperm count, sperm motility, sperm morphology. And when you look here, it says that 16 million sperm per milliliter or above is normal. But this 16 million sperm per milliliter reflects only 5% of the population. In other words, 95% of the guys who are able to conceive have more than 16 million sperm per ml, right? And this is a question. So if 16 or higher is required, does it mean that 20 million is normal? And to answer that question, the World Health Organization actually created a slide chart where you can try to fit you in on in which percentile you are. And that's shown in the next slide. Here we go. Let's see here, sperm concentration. So sperm concentration, if you go to the 5th centile, again, it shows 16 million sperm per ml. But if you go to the 10th centile, it goes to 22 million sperm per ml. Does it mean then that 20 million sperm is normal because it's above 16? No, it just means that you have a little bit more chances. But when you look at the average, it's 66 million sperm per ml. So you are looking at, if you want to see if you are, if you have 50% chances of conceiving and 50% chances of not conceiving, that number will be much, much higher than the required by the World Health Organization. So we must be very careful when we are analyzing sperm semen analysis, because semen analysis is a very good test on the extremes. If you have such a very good test, nice, good for you. If you have a very bad test, like no sperm at all, then it shows that you are azoospermic, and you are infertile. But sometimes you may have 2.5 million, 5 million, and still you are still able to conceive. And sometimes you have 40 million, and unfortunately, something is going on. So that's why we are more than ever looking into sperm quality and not only into what the semen analysis is showing us. Next slide, please. So this is another test that is another study that was done trying to find out what would be the ideal number for a man to be considered fertile or infertile. And then what this, and this is very important, all women that participated in this study, they were tested before and excluded any cause of female infertility. This is only due to male infertility. So what they found out is that men who has less than 13.5 million per ml, pretty likely, close to that 16 million that the World Health Organization says, they are more likely to be infertile. And men who have more than 48 million sperm per ml, they are more likely to be fertile. So there is a limbo between 13 million sperm and 48 million sperm that those guys may be either on the fertile group or the infertile group. And that's where it's important, a thorough evaluation. Next one. The most common cause of male infertility is a condition that is very easily fixed. And that's this disease here called varicocele. Varicocele are dilated veins around the testicle. It's like having the same varices that we have on legs in our scrotum, right? And what that varices do, they increase the temperature around the testicle, and they also increase the exposure to radical oxidants to the seminal fluid, and that can harm sperm ability to penetrate the egg, and they can also break the DNA of the sperm. And this is easily treated with a surgery. It's an outpatient surgery. It takes about an hour and a half. 4 months later, 70 to 80% of the patients who are submitted to surgery have an improved sperm count. So this is very important. It's only noticed during a physical examination or a scrotal ultrasound. Usually patients do not feel that they have a varicocele. They are completely asymptomatic. Exception is when the varicocele is very, very big and they feel that there is something else on their scrotum apart from the testicles. They feel like having what we call a bag of worms inside of the scrotum. Okay. Next. So this is a meta-analysis. A meta-analysis is a compound of several studies done in infertility relating varicocele and pregnancy. And here it says that odds ratio favors surgery. In other words, if you have a varicocele, you have, and you do surgery, you have 2.9 times higher chance to conceive compared to those who have not done a surgical procedure. So almost 3 times higher chances of conceiving if you do have your surgery. Next. And more importantly, even if the female has some problem and IVF is indicated for her, if you treat the male who has a varicocele before the IVF cycle, chances are also greater for those who have the varicocele treated. They have more embryos fertilized, they have more clinical pregnancy, they have less chances of miscarriage and higher live births. So whenever we have a varicocele, ideally we should treat with surgery, either to conceive at home, either to do any treatment at the lab, IUI or IVF. Next one, please. I mentioned this briefly, and this is very, very important because nowadays what we are seeing is that this is probably the second most common cause of male infertility today. There are many, many men on testosterone supplementation. They may not be using, testosterone shots, but they are taking testosterone boosters. And those testosterone boosters may also decrease sperm quality. So remember when I talked about the baby sperm maturing to an adult sperm? In order for this to happen, we need a hormone called testosterone. And if I'm receiving testosterone from the outside world, my testicle will completely stop their ability to produce testosterone. And that testosterone that I'm using from the outside world does not get into my testicle. So, in other words, my maturation will arrest. I won't have any sperm more. This is very important. because many men wants to have, more muscle, more lean mass. They want to perform better in life because testosterone is important for mental health, physical health, sexual health. But if they are trying to conceive, there are safer ways to increase testosterone without harming testicular and sperm function. Okay. Next. Another thing that is very important, that's why I'm so thankful for Kindbody to have me here in this position, is that men with infertility has higher chances for other diseases, especially cancer and heart problems. And infertility might be the tip of the iceberg. It might be something that is showing up, and underneath that, we can find those very serious diseases. And if we are not diagnosing those patients, if there are IVF clinics out there just, overlooking the male and looking only on the female side, they might be risking important lives out there. So it's very important to know that infertile men are 3 times more likely to have testicular cancer, and 2.5 higher chance of having prostate cancer. And this is really important for us to track whenever we are doing fertility consultation. Next one. Lifestyle modifications. What can I do to improve my sperm health, my ability to conceive? So I have no doubt in my mind that if you have to take only one measure, that will be do not smoke. Okay? And do not smoke cigarettes, do not smoke weed, do not smoke anything. Smoking is a very important and harmful way to decrease your sperm quality and your sperm quantity. There are some vitamins out there and antioxidants that can help prevent the damage that smoking causes. But, if you are not seizing the cause, you are not making things better. So vitamins and antioxidants are also very important. It's very common that we prescribe vitamin C, zinc. We prescribe fish oil, and especially coenzyme Q10. They are very important antioxidants that can help with sperm quality. Maintaining a normal body mass index, it's a very important issue as well. Men that are obese, they tend to convert their testosterone into a female hormone called estradiol more easily, and that estradiol causes a negative feedback to their testicle, producing less and less sperm. Maintain your sugar levels. Wear loose underwear for the same reason as I mentioned for varicoceles. Tight underwears, lycra underwears. Some professions like being a cook, working in a very hot environment, that may also decrease sperm production. And of course, avoid elevated testicular temperatures. Try not to use hot baths, saunas, jacuzzis when you are trying to conceive. This is important. And I mentioned this several times. There is not such, there's, this is a joint workforce. REIs and urologists, they need to work together, because even if the cause is only for the male side, it's the female, it's their partner who will get pregnant at the end. So we need to be very, very well tied together on the diagnosis and the plan that we are planning for that couple. Next one. Do you want to go from here,
Yeah.
Ellen?
Yeah, sure. Thank you, Rodrigo. That was excellent. So I think I'll run through this and then we'll take some questions at the end. Essentially, this is just to guide you if you're watching this webinar and you think you would like or need to be seen by a specialist at Kindbody, whether it's, a urologist like Dr. Pagani, it's a fertility specialist, a women's fertility specialist, or a couples fertility specialist like myself. We can get you started if you go to kindbody.com and you're able to schedule right from the website. We are also, like I mentioned, going to give you a survey at the end of this event where you can fill it out and let us know if you're interested in being contacted to get scheduled for a consultation, if you're interested in proceeding with fertility treatment in the near future. There's also some instructions here if you have Kindbody benefits. And you can also access that through kindbody.com and follow instructions to activate your fertility benefits. So Q&A. Rodrigo, do you have access to that, or Michelle, are you doing that? Rodrigo, you will? Okay, perfect.
Yeah, I can start there. So the first question is, how does daily marijuana intake affect sperm production and health, if at all? So I think I already answered this.
Did you say marijuana? Is that what
marijuana? Yes.
Yeah. Okay.
Yeah, smoking is very bad to your sperm function. It can be cigarettes, it can be tobacco, or it can be marijuana. You can also vape, and more importantly, there are some studies now showing the edibles may also harm sperm production. We do not have any specific data on humans yet, but we have some data on monkeys that have been using edibles daily, and their testicle size are smaller and their sperm count has been decreasing when they are using edibles. Another thing about marijuana that concerns me is that there are some studies linking marijuana use to testicular cancer. So be aware of the use of marijuana.
I think that's a great question, because I have found in the last few years, as marijuana has become legal in more and more states, that a lot of people are interpreting that to mean that it's actually healthy or okay for them to be using on a fairly regular basis, sometimes a daily basis. And I think that myth is sort of pervasive in the media too, in social media, that it's good for you and it's treating certain conditions. But I think from both the female and male fertility perspective, that's absolutely not true. It is harmful for both partners when trying to conceive.
Well said. Question number 2, if motility is around 3 to 5%, is conception almost impossible? So we do expect motility to be higher than 30%. So we are talking that you have about 10% of that of what is supposed to be normal. 3% is very low, but it's not impossible. You do have sperm, you do have motile sperm. Pregnancy might happen. 2 things. What is the female age, which is the most important factor in all of this? Okay, so this is very important. And second, is there something that we can do to help and increase sperm motility? Because sometimes when you have motility as low as 3 to 5%, it might be due to some genetic problems on the tail of the sperm, so they cannot move as well. So you really need some further investigation.
Would I be able to even dial that back a little bit? I guess I would also say to whoever asked that question, I usually like to suggest, obviously, repeating a semen analysis too. So it depends on whether this was a confirmed result, right? I think, certain things can affect results temporarily with sperm quality. And we always want to confirm with a second test before we start making treatment decisions based on just one set of results. Would you agree with that?
Oh, this is great, Ellen. Thanks for reminding this. Nowadays, Sometimes people are not collecting the sample at the lab. They are collecting on their places and then taking that sample to the lab to be examined. If this transportation takes more than 30 to 60 minutes, it will decrease sperm, number one. Number two, if there was on winter, that's even worse because, low temperatures will decrease sperm motility. So if this sample was not collected I would say in a good environment, we should repeat semen analysis before saying that there is a problem. Very well said. The third question is, what happens if you didn't abstain before the sperm test? Well, sometimes it doesn't happen anything. You might have a lot of sperm and that's good enough, okay? But most of the time, and that's how, the World Health Organization decided what is normal and what is abnormal, was comparing guys who were between 2 and 5 days without having sex, without having an ejaculation. So sometimes you can go there having an ejaculation the day before, and on the following day, you still have plenty of sperm. But other times, you might have no sperm at all or very little sperm. And then, for sure, you will need to repeat the test. Okay, so this is the Q&A. I'm going to webinar chat. There are some questions on the chat as well. Formal sperm testing is a lot more than the drugstore testing. Oh, this is important. There is one drugstore testing that is called the EO testing that looks like a pregnancy test where you just have a marker, and that marker means you have such an amount of sperm higher than the threshold that 15-16 million sperm. But that will never tell you how many sperm do you have, what is the motility of that sperm, and what is the morphology of that sperm. So I will never substitute a formal test for the drugstore. Now, there are some testing coming out there where you can ejaculate and mix your ejaculation with some sperm-friendly media, and we can look, and that sample, we ship it to a laboratory, and that can be done, overnight. So those semen analyses are more reliable than just, those semen analysis that, the sperm test that just tells you if you have or if you have not such an amount of sperm. Next question is, what does hormone testing show? Phthalates and endocrine disruptors. So when we are looking, for hormone testing, we are looking for, especially, we do at Kindbody a full panel with 9 different hormones. But I will tell you 2 that are the most important ones. FSH, follicle stimulating hormone, and testosterone. FSH measures how well your testicle is functioning, and testosterone measures how well you can mature your sperm. So the higher the FSH, the worse it is for sperm production, and vice versa. The lower the testosterone, the worse it is for sperm production. Except on the cases where men are taking testosterone shots and their testosterone are very, very high, what we call supraphysiologic range. On those cases, high testosterone is also harmful for sperm production. About the endocrine disruptors, this is very common on this plastic material that we use for drinking waters, and
yeah, definitely.
I
think the endocrine disruptors are interesting because they affect both the female and the male partner. They're going to be a set of chemicals, of which there are thousands, right, in our environment that we're exposed to, almost too many for us to really track. And the way I talk to patients about trying to minimize toxin exposure in general is, and therefore the endocrine disrupting actions of these chemicals, is starting with simple changes in their household. You know, I start by exactly what you said. You know, if you're using plastics in your kitchen, you know, so you want to switch to maybe glass or stainless containers to store your food, and you definitely don't want to heat your food in plastic, you know, type Tupperware containers, because the chemicals can leach from the plastic into what you eat. I also think that, you know, if you're drinking hot drinks or even plastic water bottles, those disposable water bottles that a lot of people use, just drink it and throw it away or recycle it. You never really know how those water bottles were stored before they were shipped to the store. And so sometimes if they were hot, then the plastic chemicals will leach into that water, even if when you get it, it's not a hot bottle of water. So avoiding plastics for food and for drinks is really important, in switching to glass or stainless. I think that other things that I sometimes suggest, and maybe not to go overboard, and I don't know what you think about this, Rodrigo, but you did mention pesticides. There are a lot more pesticides approved for use in the US than in, for instance, Europe and other parts of the world, because they have banned a lot more than we have. And so some things are maybe good to go organic with as far as produce, and other things may be less important. But there are websites you can refer to see which foods contain higher levels of pesticides, and maybe make some organic choices there to minimize exposure to pesticides as well. But I think that, you know, it doesn't have to be throwing out every detergent or personal care product in your home, but maybe slowly kind of transitioning to ones that are more natural and have less of these endocrine disruptors in them, more clean products over time. What do you think about some of those things?
I agree completely, and I like to add another one: phytoestrogens. You know, every now and then we see patients using some herbal medications like ashwagandha, maca, tribulus. So they can increase sperm production. They can increase actually testosterone. They are quote unquote testosterone boosters, but they are phytoestrogens like soy. And that can increase estradiol production, which in turn can decrease sperm production.
So if you see a man who's using ashwagandha, do you recommend that they stop that?
I do.
Because I've been seeing a lot of that lately.
I do.
Okay, yeah. That's interesting. Very interesting. I agree. I think that, you know, that's a good point, because a lot of people are very supplement happy. And, you know, sometimes when I ask them, okay, well, they'll tell me what their supplement is called, and it has a title, right? It has a name, but it has 18 different components. And when I ask them what's in it, they don't really know. So
yes,
it's important to really kind of look at each component of any supplements that you're using, and make sure if there's either data saying that it's potentially not helpful for fertility, for, you know, male or female fertility, or if there's no data, then it's probably better to stop using it, because there aren't going to be a lot of great studies on a lot of these things.
There aren't great studies done on these medications, on these you know, herbal medications, and most studies that we have over there are anecdotal. They are just, you know, some cohort that was followed, but and description of what they found, but there are no what we say, you know, randomized study that can actually, you know, talk in favor of using those medications.
Right. Absolutely.
All right, let's go on. What if the man has 2 kids from 10 years ago? Well, 10 years ago, probably his health was completely different. It means that
exactly
he needs to go to evaluation. His testosterone probably will be lower than it was before. And also, if he has varicoceles, varicoceles tend to decrease sperm production with time. So when he was 25, he might have had 50, 60 million sperm per ml. And when he's 35, he might be producing 20 million because of those varicose veins. So yes, he needs evaluation. Another one, can enlarged prostate impact male fertility, particularly sperm quality and numbers? No, usually enlarged prostate does not have anything to do with fertility. Sometimes the medication, if you do have an enlarged prostate and you need medication to decrease your urinary symptoms, that can cause retrograde ejaculation, and that is a problem. It's not a problem to the sperm per se, but the quality of the ejaculation. So the answer usually is no for enlarged prostate and infertility. Another question, my husband is over 45 and was tested last year for his sperm count and it was fine. Does he have to get tested this year? We dealt with life challenges last year and we are a better place this year to move forward with family planning. I usually ask my patients to have one semen analysis per year. So yes, probably it's a good fit for him to have another semen count. And if he's over 40, I would definitely do endocrine evaluation as well. So check his hormones for sure.
And that same can be said for female partners too, that if fertility evaluation was done in the past, but it's been more than a year, we're going to ask that be updated, just simply because things can change with egg quality over time and also overall health that impacts other factors related to fertility. So just like you said, we're all changing, we're human beings, and time can change what's going on with us physically.
Wonderful. 3 more questions at Q&A. Have you ever seen a higher number of issues with sperm from type 2 diabetics compared to non-diabetics? Usually not. So the fact that you have diabetes is not a problem per se. Now, it will depend on how your endocrine evaluation is. 50% of men with diabetes have low testosterone. And with that said, those men with low testosterone will produce less sperm. So it's pretty common that we put men with type 2 diabetes on medication to increase their testosterone to improve their semen parameters. Okay. Next question. I have heard that sperm quality is the best in age 18 to 25. Should male consider sperm freezing in these ages? Does Kindbody provide this kind of service? Yes, we do freeze sperm. And yes, the earlier you think about your family, the better. And that's truth also for females. The younger you are, the best it is to freeze your eggs and prepare for the future. Yeah, Ellen, something?
Absolutely. Yeah, absolutely. Yes, we definitely provide egg freezing and sperm freezing services. And I think that, from the female perspective, we're becoming more and more proactive when it comes to egg freezing. So I see no reason why we couldn't be more proactive with sperm freezing as well, because you never know what health changes men will undergo and what can happen. And we have had a shift even in our timeline as fertility physicians as to when we were recommending egg freezing. We used to say, okay, if you're hitting, mid or second half of your 30s, like 37 was a magic number at one point. If you aren't trying for pregnancy, freeze your eggs then. And then we started to realize that we'd really perhaps done a disservice to some women who were already showing signs of significant reduced egg supply or lower ovarian reserve by the time they were in the second half of their 30s. So now we've sort of moved that up to say, well, if we want to freeze eggs and we want to try to get a good quantity of eggs and one egg retrieval for you, and if you want these eggs in the future, maybe think about doing that at a younger age. So from our perspective, we definitely would love to talk to women kind of at any age, even late 20s and around 30 about that is when we would start the conversation.
Wonderful. Last question. Are there supplement ingredients you would recommend to keep man or woman fertility in top shape before testing? Well, that depends on how long you are trying. If you're trying for more than a year, I would not think about supplements, because I don't think that will change your chances of conceiving that much. I would really go directly to testing. If you are thinking about trying and you are younger than 35 years old, then there are some supplements. I will tell about the male supplements that can be used, and Ellen will finalize with the female supplements that she uses. So for men, the most common one is CoQ10, coenzyme Q10. I usually use 200 to 400 milligrams daily. I also think that multivitamins, especially if they have vitamin C and zinc on it, it's an important is important for sperm production. And lastly, fish oil. It's another thing that is important for the sperm membrane to be well formed.
Yeah, I agree. I think, you know, if I'm just sort of empirically starting supplements, those are the things that I would typically suggest for the male partner. For the female partner, it's quite similar, actually. So obviously a prenatal vitamin is important, or if you're just planning to freeze eggs and not planning for pregnancy, you can substitute a women's multivitamin, because we know that a lot of the B vitamins as well as the other components are good for egg health. We also suggest fish oil. It's an anti-inflammatory and excellent for, you know, overall health and egg quality. We suggest the CoQ10, and I sort of titrate the dose for that depending on the ovarian reserve. I'll start at about 400 milligrams, but sometimes we'll go higher if there are issues with egg quality. And vitamin D, you know, I will usually suggest vitamin D, because vitamin D deficiency or insufficiency can significantly impact fertility as well. We think at the level of the egg and the uterus. And so potentially I would think at the level of the sperm too. So it's safe to probably start with 2,000 IUs a day of vitamin D in addition to that multivitamin.
Awesome.
Did we catch all the questions?
We did.
Wow. Okay. Let's see. So here's our thank you slide, because I think we're just about to wrap things up. Thank you everyone so much for joining us tonight. It was great to provide this information. And Dr. Pagani, thank you so much for participating. It's always fascinating to hear you talk about this. And I think just such an important topic for couples and men to understand.
Yes, thank you very much, Ellen. You can always visit Kindbody, email us, and also reach us on our social media, Instagram and Twitter, and so on and so forth.
All right, excellent.
All right.
Everybody have a great night, and please fill out your survey that you'll receive. Take care. Good evening.
Bye-bye.
Bye.